Hello, and welcome to today's debate on the pros and cons of neurodiversity affirming practices. As the great mind of Albert Einstein once said, everybody is a genius, but if you judge a fish by its ability to climb a tree, it will live its whole life believing that it is stupid. This quote emphasizes the importance of recognizing everyone's unique qualities and celebrating each other's differences. Similarly, the concept of neurodiversity has challenged conventional views on neurological differences, including autism, ADHD, and dyslexia. And at the heart of this movement lies the belief that these differences should not be pathologized, but embraced as integral to human diversity. Leadbeater et al. Discusses in their article how neurodiversity affirming practices advocate for inclusivity, accommodation, and respect for the unique strengths and challenges of neurodivergent individuals. However, as we examine this topic, we are confronted with a few potential ethical dilemmas. When disability is defined primarily by observable behavior, one is left with the task of identifying appropriate outcome measures to assess clinical progress. Leadbeater et al. Describes how the reduction or elimination of stereotypical behaviors is often chosen as the means to assess progress by defining the attainment of a more typical appearance as the ultimate goal of service provision. This approach runs the risk of diverting more meaningful, person-centered objectives and potentially causing harm to these individuals with disabilities. Moreover, attaining more typical behaviors seems superfluous when compared to addressing traits that are inherently harmful or personally distressing, such as self-injurious behavior. Today's debate will emphasize autism and the emergent neurodiversity movement as a lens through which we will explore the intricate ethical challenges associated with neurodiversity affirming practices. But before we more thoroughly dive into this debate, allow me to introduce our debaters. First, we will have Sarah, who is neither for nor against, but rather an impartial third party, here to help highlight each side's main points. On the side advocating for the pros of neurodiversity affirming practices, we have Devin as the pro-prover and May as the pro-attacker, who will each present compelling arguments in favor of embracing these practices. On the opposite side, arguing for the cons of neurodiversity affirming practices, we have Sienna as the con-prover and Kaylee as the con-attacker, who will each provide counter-arguments and raise critical questions regarding the practicality and potential challenges associated with these practices. Each debater will be given 5 minutes to make their arguments before allowing the opposing side a 5-minute rebuttal, and at the end, we will open the floor to the audience for any questions that you may have. I am Samantha, and as your moderator, I will make sure everyone stays on schedule as well as keeps track of the visuals for our debaters. And lastly, taking questions from the audience. As you give your attention to the debaters' well-reasoned arguments, I encourage you to critically assess the information presented and consider the profound ethical implications for diversity and inclusion. Remember, our goal today is not to reach a definitive conclusion, but rather to foster a deeper understanding of the various facets of this complex issue. The arguments put forth by our debaters will shed light on both the advantages and potential drawbacks of neurodiversity affirming practices. With that, let's begin our debate. Sarah, you have the floor.
Hi everyone, my name is Sarah Armentar and I'm going to be stating the pros and cons. The pro perspective of neurodiversity affirming practices embraces the uniqueness of individuals diagnosed with autism spectrum disorder and sheds light on the importance of appropriate treatment interventions. Those that believe in neurodiversity affirming practices suggest that this neurocognitive difference is part of the rich diversity and variety of cultural backgrounds within our society. Neurodiversity affirming practices ensure that all individuals have equal rights and there is no middle ground. With that being said, interventions based on neurodiversity affirming practices oppose any attempt at treatment whose goal is to normalize or fully cure individuals with autism spectrum disorder. Neurodiversity perspectives have confidence that individuals with neurocognitive disabilities should not be treated on a set list of symptoms and vulnerabilities needed to be corrected. Rather, Neurodiversity offers interventions that assist with regulating emotions, physical health, and sensory needs. Neurodiversity also places an emphasis on mental health and the well being of the client receiving treatment. Many who believe in neurodiversity affirming practices disagree with the medical model of disability as a treatment guide. Although the medical model of disability has validity, the model specifically focuses on deficits associated with the disease and lacks emphasis on what individuals need to not only function but also thrive in society. Although members of the neurodiversity movement have advocated to pull away from the medical model foundation, advocates of neurodiversity are in favor of all interventions that positively serve the clients. These interventions must be performed in a respectful manner, improve the client's quality of life, and also have a focal point of teaching practical skills. Board certified behavior analysts provide ABA services to those diagnosed with autism spectrum disorder. In doing so, BCBAs abide by the BACB Code of Ethics. Within the Code of Ethics lies the core principle of benefiting others. The core principle emphasizes the importance of protecting not only the client's physical health, but also the client's mental health. Tying back in with the medical model of disability, interventions based on the model should also align with the Code of Ethics to protect the client's dignity and also support positive interventions. Neurodiversity additionally supports neurotypical individuals building resilience and relationships in a supportive and respectful manner. There is increasing evidence that supports intervention in an attempt to normalize this disability leads to individuals developing characteristics of masking, which leads to mental health issues. Figure 1.1 highlights the side effects of masking, which includes hiding behaviors that are not neurotypical, mimicking others' social behaviors, imitating eye contact, imitating gestures, pre-preparing phrases, jokes, and conversation, autistic burnout, sensory overload, emotional overload, and delayed diagnosis. According to the National Autistic Society, there have been studies shown that masking leads to an increase in depression and anxiety. Additionally, there is a link to an increase in suicide behaviors in those who mask. The neurodiversity movement focuses on recognizing and accepting the variation of cognition as a positive contribution to society. Neurodiversity affirming practices promote empowerment, self-acceptance, and improved mental well-being. Having a balanced viewpoint of neurodiversity addicts that specific characteristics remain unless these characteristics cause harm or become a violation of rights. Additionally, these practices foster a more inclusive society that values the unique strengths and perspectives of autistic individuals. In relation to autism, neurodiversity has many benefits. They foster acceptance, celebrate unique strengths, and create inclusive communities. By embracing neurodiversity, individuals can empower others and promote a more understanding and supportive society. Now for the cons. Those that argue against neurodiversity affirming practices instead see the importance of early and ongoing interventions for those with autism spectrum disorder. They utilize research literature as evidence to emphasize the developmental consequences of one's overall quality of life, opportunities provided, and desirable personal outcomes. In addition to the importance of research literature in early intervention, it is also important to discuss the medical model of disability. The medical model views clinical impairments as a key component to not only diagnosis, but also treatment intervention targets. The label neurodiversity dismantles the medical model, which leads to misdiagnosis. According to the Scholarly Community Encyclopedia, those that advocate for the medical model of autism have confidence that autism is caused by genetic deficits or environmental harm. They additionally believe that the validity of talents ascribed to autism does not override the deficits. The line is unclear on who is included in the neurodivergent label. Neurodiversity affirming practices create a divide amongst neurodivergent individuals and society. Neurodiversity places all individuals on the spectrum into a vague category, undermining the specific level of each diagnosis. This overgeneralization can lead to a lack of specific treatment options on a case-by-case basis. There is not one specific tactic that works for all cases. In the article, Critiques of the Neurodiversity Model, Jenny Russell discusses the act of labeling neurodivergence. Labeling neurodivergence is dismissive to those who are not specifically diagnosed with autism or have a different neurocognitive disability, such as dementia or schizophrenia. In addition to ambiguity of the neurodivergent label, those against neurodiversity question the validity of interventions provided. For example, they hold the belief that interventions such as ABA therapy are understudied and there is not enough validity to state that it is beneficial to one's mental health. Due to the lack of research and overgeneralization caused by neurodiversity affirming practices, individuals are placed into a vague category and are not provided with specific treatment options to their diagnosis.
Hi, my name is Devin, and I will be providing the evidence base today for neurodiversity affirming practices. When having these discussions about neurodiversity affirming practices, many of you might be asking yourselves, what does this have to do with me as a professional? Are these practices even evidence-based? And that sounds nice, but how do I even do that? And to answer these questions, as behavior analysts and future behavior analysts, we are called to follow the BACB Code of Ethics. The BACB Code of Ethics has 4 core principles. The 4 core principles: behavior analysts should benefit others, treat others with compassion, dignity, and respect, behave with integrity, and ensure their own competence. These 4 core principles tie perfectly into the neurodiversity affirming movement. Continuing from the Ethics Code 301, our responsibility to our clients. Behavior analysts act in the best interest of our clients, taking appropriate steps to support their rights, maximize benefits, and do no harm. They are also knowledgeable and comply with applicable laws, again, tying perfectly into the need for utilizing neurodiversity affirming interventions in our practice. Now for the evidence base. The social validity, feasibility, and acceptability of neurodiversity affirming practices are often called into question, and the McDonald study proves there is an evidence base for neurodiversity affirming practices. This study utilized the neurodiversity paradigm and had favorable outcomes in increasing self-advocacy, emotional regulation, conflict resolution, and stress management in autistic adults. Looking at figure 1.2 of neurodiversity affirming principles, these core principles tie easily into our everyday practice and are often already applied in our day-to-day practice. Respecting autonomy, presuming competence, promoting self-advocacy, and ensuring positive self-identity. Finally, how do we do this? The answer is simple. Make your client's voice matter in their treatment plan. We use methods that allow children to exercise their right to bodily autonomy. This means we listen to both verbal and nonverbal cues. Reinforce attempts to communicate the need for personal space, breaks, and assistance. All communication is valid. Concluding, common arguments against utilizing neurodiversity affirming interventions often reference the lack of evidence base. But the evidence base is out there. As practitioners, we must use evidence-based practice, and the neurodiversity affirming interventions are a part of it.
Hi everyone, I'm Sienna and I will be taking the role of con-prover. Neurodiversity affirming practices should have a place in our society. Advocacy and empowerment is important and can be very beneficial for some individuals. However, I believe it is completely unrealistic to dismantle the medical model of disability in our current world. Firstly, in order for advocacy and the protection of human rights to be operationalized, it has to exist under a legal blanket, as mentioned in the 2019 Russell article. Neurodiversity activism aims to advocate for the inclusivity and accommodation of neurodiverse individuals, as Sarah previously mentioned. But how would that be possible in a legal sense without a structured system? Unlike neurodiversity practices, this can exist within the current medical model, especially with the necessary growth in the direction of self-advocacy, cultural humility, and individual respect. My second point is, where do we draw the line of who is included in the neurodivergent label? In the article, Critiques of the Neurodiversity Model, Ginny Russell argues that the current labels could be dismissive to people not diagnosed or other groups of people, such as those with dementia or schizophrenia. As displayed in other identity politics movements, such as feminism, groups of people are often overlooked in activism and in turn experience larger gaps in resource access and equity efforts. To end this point, how would anyone be diagnosed if the medical model was dismantled? I argue this would result in more harm than the intended benefit. To continue my argument, if the foundation of the neurodiversity movement is really autonomy, shouldn't we also support the existence and use of the traditional medical model if individually chosen? Neurodevelopmental conditions can cause problems with functioning and bring a lower quality of life. This is scientifically known to be treated, not cured, with medical systems such as applied behavioral analysis. Not just by empowering the individual and/or their caretakers to believe it's all right to be neurodivergent. Sometimes it's not just the society disabling individual, but rather the fact that they are significantly intellectually disabled and would greatly benefit from medical-based treatments. Referring to figure 1.3 on the PowerPoint, there are multiple options available for the treatment of autism or other neurodivergent diagnoses. It is up to the individual and/or the caretaker which method they choose. There is no expectation that individuals take medicine to treat their symptoms. It is widely accepted to use a more social approach with educational and behavioral treatments. The neurodiversity movement could also lead to a lack of needed resources available for higher needs autistic individuals. As quoted in the article, Annual Research Review, Looking Back to Look Forward, Changes in the Concept of Autism and Implications for Future Research, Francesca Happ and Uta Firth state, if impairment is a function of the interaction between the person's characteristics and the demands of the environment or context, this means that an autism diagnosis based on current behavioral assessments could potentially come and go. It isn't fair to overgeneralize neurodiversity to the whole group of people under the spectrum. Some need more therapy than others, and that is their choice, and they shouldn't be berated for it. To close, the BACB Ethics Code states in Code 1.01 that it is imperative to rely on scientific knowledge in our practices and when implementing treatment plans. It would be unethical to support a treatment that is not evidence-based and exists out of the realm of science, such as neurodiversity affirming practices.
The medical model of disability, also known as the conventional medical paradigm, believes autism is a disability rooted within individuals. Within this paradigm, Pelicano and Dan Howding in 2022 stated disability is a consequence of a person's biological makeup and functioning. Within this belief, disability is defined as any restriction or lack of an ability to perform an activity in the manner or within the range considered normal for a human being. If we are using the beliefs held by the medical model of disability, there is an assumption made regarding there being the existence of a normal level of ability that is held up as the ideal state of health, and those who do not fall within this normal level of ability are labeled as almost undesirable or of having undesirable features. If we look at figure 1.4, neurodiversity can be broken down into the idea of celebrating variation in human brains or human minds. So what is neurodiversity? Neurodiversity is the idea of the variation in human brains as being biologically normal and adaptive, with no one brain being prized as ideal. This medical model tends to divert attention from autistic people as individuals and does not give credibility to their ability to understand autism and the impact it has on their own lives. The medical model does not need to be dismantled. However, it does need to be revised to include neurodiverse populations in a more individualistic manner. Researchers have used reports from caregivers, teachers, and other information sources, as well as observations based in a laboratory setting, in order to conduct studies based on neurodiverse populations. There is little research conducted using first-hand accounts from neurodiverse populations, specifically individuals with autism. This leads back to the idea that those with autism cannot understand their condition, which has damaging effects to autonomy and self-determination, as well as a potential data integrity issue on previously conducted studies, considering the biases involved. Neurodiverse populations have little self-determination and often are not given the opportunities to influence what, why, and how research is conducted in these sciences. Research suggests that non-autistic individuals have difficulties understanding those with autism, their behaviors, and the way that their mind works. This may lead to misperceptions in autism science and perpetuate harmful stereotypes, such as dismantling the medical model is completely unrealistic in our current society, or that neurodevelopmental conditions can cause problems with functioning and lower quality of life. Neurodiversity affirming interventions give necessary credibility to individuals who are systemically withheld from self-advocacy, self-determination, and self-worth. If non-autistic researchers have difficulties understanding the mechanisms of the mind and behaviors of neurodiverse individuals, using neurodiversity affirming interventions will lead to a deeper knowledge and ultimately a better world for those living with conditions that fall under that neurodiversity label. If clinicians and healthcare professionals were to follow the BACB ethics code, specifically 3.12, advocating for appropriate services, there should always be an emphasis on advocating for the appropriate services of clients and their caregivers. It is also necessary to advocate for the appropriate amount and level of behavioral science provision and oversight.
Hi, my name is Kaylee, and I'm taking the role of con attacker. Different symptomatic interventions, such as ABA therapy, are understudied in regards to their ability to improve mental health in individuals with autism. A recent study from 2023 has shown that there is not a sufficient amount of research to support that these interventions are beneficial to mental health. Neurodivergent impairment is said to be an illness between an individual and society rather than an individual dysfunctions. With this being said, neurodiversity affirming individuals express social barriers that marginalize neurodivergent people, treating them as insignificant when functioning in society. A study by Pantaskos and Vanaken explains that neurodiversity affirming individuals want to fight against social exclusion by allowing neurodivergent measures such as self-advocacy and education, but neurodivergent affirming practices and individuals are the ones that cause a divide between neurodivergent people and society in the first place. According to an article by Ballou in 2022, there are aspects of autism that society cannot accommodate, stating that accommodations don't solve everything. This article also explained that disabled people are not disabled by their physical or sensory impairment, but by the failure of society to accommodate people with these conditions in the same way as it does people without them. Examples of this include lack of ramps and wheelchair accessible things and places. To add to that, practices such as ABA attempt to reprogram and mold autistic individuals into having neurotypical behaviors. Harmless behaviors such as stimming are reduced, changed, and shaped, which deprives these individuals from self-regulation tools and techniques. A recent article explains that controlling and shaping social behaviors such as eye contact also causes distress to the individual. Causing distress to the client from controlling and shaping behavior violates the BACB Ethics Code 3.01 responsibility to the client. This code means that the best interest of the client is taken into consideration, along with supporting the client's rights and doing no harm to the client. Causing distress is not in the best interest of the client and causes harm. Practices such as ABA therapy target the more severe symptoms associated with autism, but since they are all symptoms of autism, this can cause autism camouflaging. The study from 2002 of Pantaskos and Vanaken explains that autism camouflaging is directly related to higher rates of depression and suicide and reduced mental health and well-being.
In conclusion, Today, we have heard persuasive arguments made by both advocates and critics of neurodiversity affirming practices. On the one hand, our proponents have emphasized the importance of equal rights, self-acceptance, and mental well-being for individuals on the autism spectrum. They've argued that these practices empower individuals, foster acceptance, and create a more inclusive society that values their unique strengths and perspectives. On the other hand, our critics have raised valid concerns about the potential drawbacks of neurodiversity affirming practices. They've pointed out that the label neurodiversity can be overly broad and may lead to a lack of individualized treatment options, potentially undermining the unique needs of those on the spectrum. Additionally, the unclear boundaries of who is included in the neurodivergent label have been questioned, as well as the validity of certain interventions like ABA therapy. While this debate has highlighted the complexity of this topic, it is essential to remember that ultimately we should seek a balance that respects the needs of each individual while promoting inclusivity and understanding. I will now open up our debate to our audience for any questions they may have. Our first question of the day: do you have any advice for a BCBA or RBT when a family wants to work on a behavior that is clearly not a priority for your client at that time?
When providing feedback to a family on their child's behavior, it is important to understand the social significance of the behavior for that family. The BCBA should be empathetic of the family's culture, as well as be able to address the information using background information. Data collection graphs of targeted behaviors can be utilized to explain to the family behaviors that are being targeted and why these behaviors take precedence over the behavior that they are concerned about. To use self-stimulatory behaviors as an example, the behavior should first be explained and identified to the family. According to the American Psychiatric Association, individuals with autism spectrum disorder are very likely to exhibit repetitive movements identified as self-stimulatory behaviors. In relation to the severity of targeted behaviors, unless the self-stimulatory behavior is causing physical harm to the client, then other behaviors should be prioritized. Research articles should be provided to the family to effectively explain why self-stimulatory behaviors are not a priority for the client.
Thank you, Sarah, for your insightful response. Our next question is: how might a BCBA approach this discussion with a client and his or her family?
When approaching a discussion with a client and their family on an intervention that might not necessarily align with neurodiversity affirming interventions, it's important to meet them with compassion and empathy. Just like our clients, they're learning one day at a time. It's also important in this moment to remember what might not be socially significant in our culture might be socially significant in another culture, and vice versa. Discussions like this are wonderful moments to offer replacement behaviors and provide them resources and information to support them in this journey.
Thank you, Devin, for that thoughtful response. Our final question is from the audience is: how can a BCBA really take a client's perspective and wants or needs into consideration when planning treatment goals?
Before treatment goals are even developed, it is imperative that we as behavior analysis assess the priorities and goals of our clients and their caretakers. We can do this by disseminating introduction surveys that cover topics spanning from behaviors to home life and any other individual-based information. During the stage of behavior intervention, we should arrange parent meetings to stay up to date on the client's wants and needs, along with making sure we facilitate a positive relationship with the family and other stakeholders. This could be done by answering questions, planning parent trainings, and facilitating conversations around new research in the field of ABA.
Yes, and to add, client preferences should be analyzed throughout the course of treatment. This involves all clients regardless of their communication method. To ensure assent to treatment is present and ongoing, indicating likes and withdrawal of tracked. When tracking indicating likes, the clients will use indicating responses to declare motivation or desire for an item, action, activity, something that they want continued. This may look like a client making eye contact, gesturing, or vocally demanding for the activity to continue. When tracking calm withdrawal of assent, the goal is for the client to calmly indicate refusal, rejection, dislike for an item or activity. This could look like pushing the item away, not responding, turning away, or some kind of vocal rejection when a demand has been placed or signaled. Disruptive withdrawal of assent could look like falling to the floor, elopement, and crying. Ultimately, all behaviors associated with indicating likes and dislikes or that disruptive withdrawal of assent should be personalized to the client, because ultimately the treatment must be individualized to each client and should be updated frequently.
A big thank you to both Sienna and May for answering our last question, and an even bigger thank you to everyone out in the audience today for your interest and participation in our debate. We hope to see you next time, and have a great rest of your day.